Welcome everyone to today's webinar. This is Kayla Hayward with the American Hospital Association, and I'm pleased to be moderating today's webinar, Leveraging Technology and Workflow Optimization to Address Social Drivers of Health. Today's event is sponsored by Unite Us. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by selecting the Q&A feature you see on your screen. We'd like this session to be interactive, so we are looking forward to hearing your questions. If at any time you are having trouble with audio, please try refreshing your browser. You may also submit any technical questions into the Q&A box. At this time, I'd like to thank today's webinar sponsor, Unite Us. In today's webinar, we'll explore how healthcare organizations are leveraging innovative technology and optimizing workflows to address social drivers of health effectively at scale. This webinar will feature insights and lessons learned from leaders at Yale New Haven Health System and Presbyterian Healthcare Services, who are transforming patient outcomes through cutting-edge social care solutions. Allow me to introduce you to our panelists for today. Joining us from Presbyterian Healthcare Services, we have Tony Grinstead, Health Equity Consultant, and Lee Caswell, Vice President of Community and Health Equity. And joining us from Yale New Haven Health, we have Polly Vanderwood, Executive Director of Population Health and Clinical Integration, Center for Population Health, as well as Emily Myron, Health Equity Operations Administrator for the Office of Health Equity and Community Impact. Welcome to all our panelists today. So glad you all can join us. So to kick things off, I'd like to start with Lee and Polly. Can you share with us an overview of your health system and your approach to addressing social drivers of health, and what initially motivated your organization to prioritize this work?
Sure. I'll go ahead and start. Great to be here today. Thank you for this time. So I'm Lee Caswell with Presbyterian Healthcare Services, and we are a not-for-profit integrated healthcare system in New Mexico. We have 9 hospitals, 2 ambulance services, urgent cares, and a health plan. And in New Mexico, we have a large portion of our patients who are on Medicaid and Medicare, so one of the largest in the country. So this work is incredibly important because of that. So our social drivers of health strategy has a community focus, which is about partnering and investing. And then we also have clinical strategies related to community health workers, social needs screening and referral, and then programs like a food pharmacy where we're actually addressing some of these social needs directly with our patients. And this work began in response to our community health assessment process and really hearing from our communities that if we're not addressing these social drivers of health, we're not addressing their priorities, and that healthcare really does have a role to play in that. We were Accountable Health Communities awardees in 2017, and that's when we really began the process of hiring community health workers, figuring out how to screen for social needs in the delivery system and refer out to community partners. And then ultimately in 2021, we implemented universal screening throughout our system and have completed more than 3 million screenings of social needs for our patients since that point. So that's a kind of an overview of what we do. I'll pass it to Polly.
Thanks, Lee. Pleasure to be here with you as well. And Yale New Haven, if you're not familiar, we're a large academic medical center. We're located in Connecticut. We have 5 hospitals that span the region. 2 of our largest hospitals are safety net hospitals in the state of Connecticut, so Bridgeport Hospital and Yale New Haven Hospital. So we are one of the largest providers of Medicaid and uninsured services in the state of Connecticut. So similar, I think, to what Lee mentioned, was really core to our mission to understand how the social drivers of health really impacted the health of the communities, given the populations that we were serving. Our work also started pretty early on. In 2016, the state of Connecticut had a community, it was called Community and Clinical Integration Program grant that was piloted at our Bridgeport Hospital, and that provided seed funding for our first community health workers and the start of our screening program, which was on good old paper and pencil at the time with very low tech solutions. And then we also participated in the Accountable Health Communities grant in our New Haven locations starting in 2017. So both of those grant opportunities were important to us, just given the populations that we served and the understanding that these were really important initiatives for us to be a leader in, both for our state and federally. And so the grants really provided a great opportunity to kick off that work. And then I want to say 2021, 22 really started our scaling of this work across our health system. So now we screen all inpatients across all 5 of our hospitals. We screen in primary care, and we've implemented a broader community health worker program, referral program, and Emily will talk about the work we do out in the communities to build those relationships and the investments that we're making there as well.
Thank you so much for sharing that. The key background knowledge there is great. Just a follow-up question for both Polly and Lee. How have CMS requirements for SDOH screening impacted your organization's strategy and workflows?
Yeah, great question. I guess I would say that it hasn't necessarily because we had already decided to scale up to universal screening, which we do every 6 months, no matter where you end up within our system, specialty, inpatient, outpatient. So we had already done that. I think what it did is help to elevate the work and why it was important, and kind of brought more people on board with understanding the why and seeing the regulatory and accreditation impact of doing this well.
Yeah, I would say that was similar to our experience, Lee. We were already well down the path of starting to expand the work. I think the part of the tipping point was also the Joint Commission accreditation requirements that I believe predated the CMS requirement. And we were, I believe, one of the first hospitals to be surveyed after those requirements went into effect for the Joint Commission. So we had been able, through some of our leadership rounding and designations of champions at different delivery networks, really to establish that foundation early on and get the buy-in. And so when the CMS requirements kicked in the following year, we were already well down that path as well.
So just to build on that last point, Lee and Polly, what are some of the biggest challenges your organization faced in implementing an SDOH strategy, and how did you overcome them?
Yeah, so I think, the whole 5 years of Accountable Health Communities, which was really meant to measure if screening for social needs and referring to resources improved health outcomes and reduced the cost of care. In that whole 5 years, we screened 25,000 patients. And as I mentioned, since then, we've screened over 3 million. And so taking that leap was a big challenge, and integrating our technology platform into Epic. And, that was a huge challenge and took a ton of time and resources. And also building a sustainable community health worker model, really showing the value of not only do we need the social needs screening and referral system, but we need the social care workforce integrated into the system as well. And that's an ongoing challenge, although I think we're making a lot of progress in that area.
Yeah, I would say some of our challenges were really around hesitancy to screen if there were not necessarily resources in place to address. We heard that time and time again, again, because I noted, we knew the communities that we served, we were, just by the nature of asking the question, you were likely to uncover things. And our clinicians knew that already. But, one of the things that was really impressive was just even our frontline staff felt really strongly that this was the right thing to do because they understood that these were challenges that our patients were experiencing. So part of it was really having, clinician leaders, nursing leaders. We used our nursing governance councils. Really, as we started to think about scaling this, going through those various channels to get their voice in the process, to really think through how to support them and some of their fears or concerns they might have with even asking the questions. And then we utilized our community health workers with some scripting and training because they really understood how to ask the questions too. So by doing that, I think we really empowered, our clinicians to speak up in terms of what would be meaningful and impactful to help them with this process. And then we leaned into some of the experts that we had within our organization to really provide that training and background as well.
Thanks. Thank you, Polly. Thank you, Lee. Just shifting gears a bit, and I'll direct this next question to Tony and Emily. At a high level, can you walk us through your SDOH screening and referral process? For example, what happens after a patient is screened for SDOH needs, and what role does technology play in this process?
Yeah, sure. Happy to speak to that. At a really high level, our screening and referral process is universal, standardized, it's integrated across our whole system. And the expectation is that patients will be screened at least every 6 months. And the screening is actually hardwired into our clinical workflows within our EMR, which is Epic. So it's not dependent on, individual provider discretion, or it's not role specific. And once a patient completes the screenings, our EMR ingests that information and then displays it visually in a wheel that's located in a very conspicuous spot in the patient chart. And it displays whether the patient is at risk for any of the social needs based on their responses. And so that's visible across all settings. So that means that providers and care team members can see those responses from the previous screening, and they're not having to rescreen patients at every visit. It just gives everybody on the care team a really quick snapshot and kind of view of what the patient is up against in terms of like housing and food insecurity, transportation access, and then ideally that helps the provider customize the care plan accordingly. So when a need is actually identified during that screening process, we have an integrated resource directory, which is Unitas, and that automatically generates a personalized resource list for the patient, and then it drops it into the patient's after visit summary. So that takes about 90 seconds, and the patient ends up leaving with those resources in hand. And ideally, the provider also mentions to them like, hey, these resources are here, sort of points that out. And then the provider can also make a referral to one of our community health workers or a peer support specialist, depending on the context. And the really key role, speaking to the role of technology, that key role is just that it has enabled us to do this at scale. So like Lee mentioned, we've conducted over more than 3 million screenings since we went live. That breaks down to 1.5 million unique patients. And just last year alone, we did more than 600,000 unique patient screenings. So we obviously could not do that with the good old fashioned pencil and paper route, but we also have the screener loaded into the patient portal so patients can self-screen prior to their appointments during an e-check-in process. And I think most importantly, that technology is enabling that resource list to be created automatically right on the spot. So it doesn't require any effort. Providers don't have to do anything. All they do is just document the screening results, and then that process initiates automatically. And so that way we're never asking patients questions that we can't respond to on at least some level.
Thanks, Tony. And it's funny listening to you share because we're in a very similar state at Yale New Haven. So similarly, we are screening for 4 core domains at scale: food insecurity, housing insecurity, transportation, and utilities. This is also happening in our ambulatory and inpatient environments. So in the ambulatory or primary care setting, patients can self-screen before an appointment using their patient portal, which we have MyChart, or at a kiosk during check-in. And then similarly in the inpatient environment, patients are screened by nursing staff or social work during an admission. That screening result similarly is fed directly into Epic in the SDOH wheel in a patient's chart. So it's visible to all care team members. Thankfully, we also just January of this past year created the after visit resource summary. And so when a patient screens positive, they are recommended 3 resources within their geography that they could seek assistance with. So as Polly was mentioning, that helped to alleviate some baseline fear about not having resources available to patients. So there's a primary level of education. However, if a patient might need additionally tailored assistance, they can be referred to a social worker or a community health worker who can use UniteS to set up a referral on their behalf. So within our UniteS resource directory, we have ingested our 211 library from the United Way, as well as have in-network providers for the ability to have closed loop referrals. So all of that information is contained in the patient record. So it's visible to care team members and for a patient to have reference on their behalf as well.
Great information. Just a quick follow-up question here. How have automated workflows, EHR integrations, and the screening ingestion tools helped to reduce the provider burden while improving patient care?
Yeah, I mean, I'd say that has been essential. And the fact that the screening results flow right into our reporting systems without manual entry is huge. And of course, like I mentioned, that resource list generation, that the fact that that's fully automated and care teams don't have to, research what's available for each patient. And when providers or team members are making a referral, it's all done through these embedded tools. They're not, logging out and logging back in. It's all happening within the Epic environment. So, I mean, I think it's when it's thoughtfully applied and centered on real workflows, like it's very powerful. That's what we're seeing.
I completely agree. I think it alleviates a lot of staff burden, and our partnership with our digital technology team has been really transformative in this space, ensuring that the flow sheets relate to one another and speak to each other. So all of the data is contained in-house. So it has just been, I think, instrumental in being able to do this at scale, and for our patients to know that we're not just asking a question to ask, but we have the ability to act on it fairly seamlessly within our technology portfolio.
And just to expand on that a little bit more for Lee, Polly, Emily as well, what data-driven insights have been most valuable in refining your SDOH approach? And can you share an example of how you used that data to drive change?
Yeah, great question. Well, we integrate this data into our community health assessments, and so it's just a little more complete about what at least our patients are telling us about their social needs for our communities. We also can use Epic tools. We've been using Slicer Dicer quite a bit lately, so we can see, like say if, as we've been designing our perinatal strategies, that's a focus of ours across the state. And so we can see patients who are seen for perinatal visits within one of our rural hospitals, for example, and how many of them have identified these social needs as priorities. And that can really help us to understand, do we need to really focus on transportation or food, or what are the priorities there for those patients? And that really does help us design our interventions. We also have some insights dashboards that integrate these social needs along with other factors such as age and geography. And it can, with those dashboards, we're able to see, well, what is the most powerful thing contributing to certain quality and safety outcomes that we're seeing. So it really does strengthen the work and help us to understand more what's happening with our patients.
Yeah, I completely agree, Lee. I think one of the things that we've seen as we've integrated the data, so we have built essentially a Tableau dashboard that pulls the data out of Epic and overlays it. We have a mapping software so we can see the geographies where there's high prevalence of social needs, which has been really, really powerful. You hear a lot about zip code and the impact of zip code, but to actually see the responses from your patients and to see the communities in need. And then that can help be interwoven with our community health needs assessment and other strategies there. I think one of the things that I would highlight where we're using the data right now, one great example, again, we, like a lot of health systems, are focused on readmissions. Our patients who are frequently readmitted have more than twice the likelihood of having more than one health-related social need. So again, theoretically, we were all hearing in the literature, there's, this impact on health outcomes. Now we're seeing patients that are coming back frequently into our health systems also have compound health-related social needs. We just launched a new initiative where we're sending our CHWs to the bedside of those most vulnerable patients to really engage them pre-discharge to understand and to start to develop that relationship. And then they're going to be following them out into the community to try to get ahead of some of the challenges that maybe we weren't doing the best job of being on top of, and to try to get ahead of some of those frequent readmissions. And then in my space in population health, diabetes, hypertension, a lot of our big ambulatory quality measures, we're also now able to overlay things like food insecurity, housing, transportation, to those quality measures and to see where they are really showcasing an impact on those health outcomes. So then we can tailor our strategies and interventions a little bit differently to continuously improve performance on those health outcomes.
And finally, just to build on that and kind of integrate some things that Lee and Polly mentioned, we are integrating our SDOH screening data into our community health needs assessment. And so we are finalizing that report at this time, but it's been really powerful to augment the community prevalence with our patient prevalence as well. And actually at Yale New Haven Hospital, leadership has selected food insecurity as one of our priority areas, partly informed by our SDOH screening process. So we will be able to tailor interventions, utilizing resources at the hospital and in partnership with community to really impact food access and insecurity on a community and patient level. So I think that's a really powerful insight that this data has allowed us to bring forward.
Great discussion so far, for sure. I'd like to turn our focus to provider and staff engagement. And this will be directed towards Tony and Polly. What has been the response from care teams regarding SDOH screening? And have you had to overcome any resistance from staff? And if so, how?
Yeah, that's a great question. I would say the response has evolved over time. At the outset, there was hesitation, understandable. I think there was, first of all, sort of like an awareness issue, like providers had these conversations with patients come up, but they weren't always aware of kind of the broader implications of health-related social needs, like how big of an impact they can actually have on patient outcomes. But also like just not really knowing how they could help, how they could address those within a clinical encounter. So there was concerns about scope. How much time does this add to the patient encounter to ask all these questions? How to ask some of the more sensitive questions in a culturally appropriate way. So we spent quite a while piloting this work at a few of our clinics, and we worked really closely with providers to just get a sense of like what kind of training and skill building would be most useful for them. And we spent a lot of time putting together talking points and communications and really showing how this work connects to providers' priorities like quality, equity, whole person care. And a big part of that was just building awareness around our social care teams, around the existence of our community health workers and our peer support specialists, and letting providers know that these teams are out there working with these patients and helping them access these resources when that makes sense. So we actually did a provider survey last year, and we showed what they were saying to us was that the social care workforce on site has really helped. So these roles are seen by providers as like essential members of the care team at this point. And pretty unanimously, they were like, we want more CHWs, more peer supports, because they're seeing firsthand how impactful that these teams are in improving patient experience and making sure that these patients are able to navigate some of the barriers to accessing these resources. So I talk to a lot of CHWs about their experience, and I think they're seeing that more and more providers are really seeing this work as just a routine part of care and not like an add-on or like extra work or a special program. So that's big.
Polly, would you like to weigh in?
Yeah, I really echo that, it has evolved. I mean, I think, early on, we found champions, right? We found interested clinicians, interested practices or clinical sites that were really, kind of knocking on our door saying, hey, we want to adopt this. And that still happens, which is exciting. We're just going live, for example, in our pediatric specialty sites for ambulatory, and it was really driven by leadership at the Children's Hospital coming in saying like we want we don't have a regulatory requirement, but we really want to do this. We believe in this work. So I think finding champions has been really helpful. And then I think also the concept of piloting. We did many iterations, many PDSA cycles of different kinds of workflows. And again, had different stakeholders at the table during that process. And we now have, we call it our playbook. So it's all of the documented ways in which we've found success with implementing these various workflows. And then when areas are coming to us interested in adopting the toolkit, we're able to walk them through what their options are, what fits for their workflow. So it is definitely not a one-size-fits-all approach. I think offering some level of flexibility in how they adopt the workflow, but we've really held true to they're the standard questions. It's all flowing into the same place in Epic. I think, Tony, you also highlighted if somebody asks it in ambulatory, it's visible on inpatient. So it's really, I think, been one of the most powerful screening instruments because it is ubiquitous across all of our sites of care. We recently connected with our Health at Home team and are connecting their workflows to this as well. So I think really having that one view, and, being committed to having that concept that minimizes the burden on any one care team. It's not only our primary care providers or our nurses or our social workers or our CHWs. It's really everybody contributing to collecting this information, patients self-screening. So that has also, I think, elevated the comfortability because they know that, we've been designing this with an eye towards making it, not as overwhelming a burden as possible.
And just to build on that just a bit, and I'll position this for both Tony and Emily. What best practices have you developed to incorporate addressing the SDOH needs more seamlessly into clinical workflows without adding the unnecessary burden?
Yeah, I think that when we were standing this up, our probably key guiding principle was making sure this was easy and sustainable for care teams. So our best practices focused a lot on integrating into what already existed and not creating new workflows, but also automating things in every way that's possible and that makes sense. So integrating into existing workflows across our enormous health system it meant doing a lot of customization, right? So standardization and customization. So it was building different workflows for each setting and understanding that integrating into an existing workflow in a primary care facility office is not the same as integrating into an existing workflow in an emergency department. So really making sure that we were paying attention to what's going on in each of these settings. And into the automation point, I mentioned earlier, we built the screening into these patient portals, but we also built, as a backup for when those screenings weren't completed, flags that fire off in Epic to make sure that, providers are alerted during the clinical encounter that this patient is due for their screening. We're not expecting anybody to keep track of that without, automation. And I'd say the other best practice is just that operationalizing this kind of work takes collaboration across many, many, many teams. Sustainability, like I said, it looks different in different settings. So we had to make sure that we were working really closely across several teams and we were getting that perspective from each of them. So, that operational perspective from the providers actually using the system, from the clinical informatics teams, from the analytics organizations, from the IT teams, and bringing together all of those teams to understand sort of that 360 view of what sustainability for this looks like in different settings. And then we also crossed over to our talent development team to make sure that the sort of standard orientation and onboarding for providers included this SDOH work so that there's not additional trainings that they need to be taking, but that this sort of, is just covered as part of what they're learning to do when they come on board.
I completely agree, Tony. And I think one unique resource we've embedded in a collaboration between our care signature department, my office, and the Center for Population Health has been an SDOH care pathway in Epic. And so this is flagged when a patient screens positive for having a social need. And it's another layer of education and awareness for how a care team member can help support that patient. So this was done prior to the automatic resource recommendations embedded in the after visit summary, but it provides a base level of resources by need category. So the provider is able to print or text or email a patient, let's say, a food resource directory or utility benefit information at their local community action agency. But it also instructs them how they could escalate the need or referral to a care team member and use, a resource like Unite Us or like WellList, a different vendor we partner with, and then how to integrate social worker, community health worker for more tailored assistance. So that's sort of the idea of having kind of an educational baseline and a backup if, provider needs more assistance. And we have found it to be really a well-used tool, especially by our trainees, who I think are, really interested and understand that their patients have health-related social needs. And it's often an area in which they feel like they might not be able to directly impact, but there are resources at their disposal.
Great insights. Thank you so much. As we look at community partnerships and patient impact, what are some key strategies for building strong partnerships with community-based organizations to help support patient social needs? And I'll position this to Lee and Emily.
Yeah, I love this question, and I want to answer it kind of macro and then micro, 2 examples, and hopefully address one of the questions in the chat as well. One thing that we did, because we've always asked the question, well, so what? Why are we doing this? And if we're truly addressing social drivers of health, that's much bigger than health-related social needs. And so we've been facilitating and helped to initiate a collaborative that's statewide, the New Mexico Social Drivers of Health Collaborative. And the idea there is to look at why are we doing this? What outcomes in our communities do we expect to see improve? And bringing together the whole ecosystem of the state, our state agencies, our community-based organizations, other technology providers besides Unite Us, like Find Help, our health information exchange, and really making sure that we're looking at our community organizations and making sure that we're learning from them. How does a closed loop referral system benefit them? What would the incentives be to participate in that? What is the landscape of closed loop referral systems across our state? How do we partner with United Way 211s and health information exchanges to really look at this work as an ecosystem and not place, I think there's a huge risk of placing a burden on our community-based organizations in this process. And we know that these health-related social needs, they're really underfunded. There's already this huge gap in necessary resources to address these issues. So that's one way where we hope to build accountability together about how we invest in these resources and how we understand the needs and how we build an ecosystem of these networks that really support each other and lead to something that is meaningful to our communities, an outcome that really matters to them. And then at the micro level, we partner with specific community-based organizations who are aligned with our community's priorities and outcomes that we're seeing in our organization and our patients that we need to address, like perinatal, for example. So we partner with our Presbyterian Health Plan and a member ambassador program where we actually go to these community-based organizations, fund them to help to bring community members to the table and give us feedback on the services that we provide for these populations, and then invest back in these organizations to help to build capacity to address those needs. And while at the same time, changing our system to better meet the needs of our patients, members, and communities. So I'll leave it at that.
Thank you, Lee. And just building off of that, so in each of our delivery networks for our hospitals, we have regional collaboratives. So these are run by steering committees. The hospital is a part of them. And there are representation from the CBOs in our communities that are all working towards health and wellness. So our local health departments and districts, our FQHCs, our community action agencies, as well as on the ground CBOs that assist with homelessness or food insecurity. And so these have been established for, in some cases, several decades. And so there's a real spirit of trust and collaboration and networking as well as partnership. And so they help us inform our CHNA strategy. They were on board during the vendor selection of Unite Us and participated in that process. And we partner with them sort of outside of the tool for SDOH use cases as well. So for example, coincidentally, actually this morning, I was at a local community-based organization with our United Way and several other food pantries. Our hospital donated more than 5,000 pounds of food to help alleviate a school break meal grocery gap. So when school is out of session, our public school students, miss that opportunity for free and reduced breakfast and lunch. And so I think a lot of community partnership is, building trust and really just showing up. And so that has been really powerful, and an excellent opportunity to and a reminder that our patients are also community members first. And so recognizing that the hospital is part of a larger framework and ecosystem. And so I think that's just sort of a micro example of kind of our greater partnership and community-based work.
Great example. And just to build on Emily's example, for Tony and Emily, this will go to you. Are there any other success stories that come to mind when addressing SDOH led to a measurable impact on patient outcomes or hospital operations?
Yeah, absolutely. I mean, it's been really powerful seeing how this work has improved patient outcomes, but also hospital operations. Before we had the standardized process, providers, they really didn't have a way to address things like housing and food insecurity. And these would definitely be things that patients would bring up during their encounters, and then that would sometimes leave the provider in a space that was difficult, right? Like, do they not have that conversation? Do they shut the conversation down? Do they get on Google and start, pulling up phone numbers for food banks? So do they refer to a social worker, even if that's not the right fit for, a food insecurity need? So um, I think what we heard, qualitatively, is that this has really contributed to that type of moral injury had really contributed to provider burnout, and that's that sort of moment where like a provider's reasons for being in the line of work they're in just isn't aligned with what they're actually able to do for patients, and what that does internally for someone in that position. So I think what we heard over and over through our survey processes, our key informant interviews, was that embedding the screening and this type of a, even simple response to it, like a resource list, and the fact that that's automated, has really like taken this to the next level for them. So, I think we have seen meaningful reduction in friction for these providers, meaningful increase in their satisfaction in their work, their joy in practice, just that they have a straightforward way to respond to patients who may bring this stuff up to them. And then on the back end, we've been using these tools, and dashboards that help generate insights from the social needs screening data. And we can talk later, I'm sure, in the Q&A about the insights dashboards that are available for tracking closed loop referrals and what those outcomes look like. But from just an understanding of the data perspective, being able to use the insights from our social needs screening data to drive site-specific action planning for these populations, right? So from a systems perspective, we're just delivering more focused support for these patients, and that's a huge win.
I agree, Tony, and I think just pigging back off of that site-specific action plan, one partnership that comes to mind is for our pediatric asthma patients. So pediatric asthma was identified by the community as a big burden that had a lot of disparities within the city of New Haven. And Fairhaven, which is a local federally qualified health center and integrated into our EMR system in our primary care consortium, was identified as a site that a lot of families and children with asthma were coming to. And so through the Unite Us tool, they have been able to form a partnership with the Hispanic Federation, which is a community-based organization. And so they are able to send closed loop referrals on behalf of children with asthma to the Promodoras at the Hispanic Federation, who have the ability to go and do home assessments and really speak to the patient's need. And so that to me is just sort of one case study of how identifying a social health related need, and then the ability to integrate it into a referral process using a tool like Unitas has been able to be really impactful on hospital operations and patient care.
I would also, one of the things, we're talking about social care referrals at Yale New Haven. We've also spent a lot of time over the better part of 2 years, really redesigning our whole post-discharge outreach and transitional care management program. And so when I think about the impact of the screening and the referrals on hospital operations, one of the things that we heard, even on, from inpatient case managers and social workers, they don't necessarily follow the patient after they're discharged. And so they, would sometimes, have needs identified. They may connect a patient, but they wouldn't necessarily follow the patient after they had left our four walls. And once we put in our post-discharge outreach program where we're calling all of our patients discharged within 24 or 42 hours, they're able to see the screening. There's a way for the social worker or case manager to flag any concerns that they want to be followed up on during that post-discharge call, and then carrying it all the way through to being able to enroll a patient in one of our community health worker or chronic care management programs. So we're really trying to wrap around more services for all of the ways in which we can support patients' needs, decompress the burden on the inpatient units, and then provide that support to the patient during those very vulnerable transitions from the hospital back out into the community.
Great discussion. And just continuing with Emily and Tony here, as we look ahead, what advice would you give to other health systems looking to advance their SDOH strategy and technology?
Yeah, my biggest piece of advice would be starting with the relationships and buy-in before shifting over to the workflow, before building out the technology. We really had to go in and design a workflow for each setting, like I've mentioned. And we had to do several rounds of revision after this went live to, we saw data showing like, this is not happening, right? We've got it embedded in the emergency departments and we're having like no screenings there. So looking at that data and then conducting rounds of key informant interviews to understand like, how do you respond when this pops up, and hearing over and over people saying like, oh, we click out of it and get it out of the way, right? It's in our way. And then kind of using that information to realize, to sort of refine like, where in the emergency department workflow does this belong? It's, we have it in the wrong spot. So I think being able to go in and understand sort of how each space is working separately, and then also being set up to respond very quickly when we heard that feedback from providers, and being able to like push through a change on the setup of it in 48 hours, and really building that capital with them, that like there is a team. This isn't a process that's been created and shelved and forgotten about, but that there are like dedicated, committed resources to making sure that this works, and that we're continuing to do quality improvement and quality assurance work around it. I think that that's gone a really long way towards building that trust and that buy-in from providers over time.
I agree, Tony. I think from a community partnership perspective, starting and leaning in with a listening posture to understand their workflows, their needs, how they connect with patients already, what kind of referral process and mechanism makes sense for them. I think a theme I've heard throughout this conversation is, we understand that our social ecosystems already are overburdened and under-resourced. And so it's elevating their expertise and making them decision makers in the referral process, so they feel supported and empowered by the hospital, because they exist and they're there and they're willing to help. And so it's ensuring that both our patients and communities can feel supported in their journey. And so I think, the biggest thing is, right, like relationships build at the speed of trust. And so it's being a consistent presence and being, having integrity and being accountable, and doing, I think, all the things that Tony said, being flexible, and willing to do the dirty work. But I think it starts with the relationships before you can bring in kind of the workflows and the technology piece. But having that on the back end and knowing that you can automate these processes as well, it's really beneficial to the folks on the ground.
Thanks. So as we wrap up here, for Lee and Polly, what's next for your organization in terms of scaling or evolving your SDOH initiatives? And are there any emerging trends or work you're excited about?
Okay, I love this question. I think Tony mentioned the quality improvement. Continuing to do that is really key. And working on our social health workforce, so community health workers, peer support specialists, how do we really scale and sustain that workforce? Because that's key to the success of this work. And then really expanding our partnerships and investments with community-based organizations. I think we need to continue in healthcare to ask, what is our role to help to address housing, to help to address transportation? And that looks different in every community, but we can't solve it alone, which leads me, I guess, to the next thing, which is continue to partner in the community and help to be a convener about how do we solve these issues together as a state and as in our local communities. And then I know there was a question about this and Tony answered it some, but also, how do we measure the impact of this work? We're relying on what CMMI and CMS found as far as the reduction in cost of care and improved health outcomes for this model, but we'd love to see that in our own patient population, and that's just really challenging to single out, this intervention and the impact of that. So continuing to think through how do we measure impact.
Yeah, so much of what you say, Lee, really resonates. I think there was the theory right before we collected the data, and now we're seeing just through the massive amounts of screenings that we're doing and being able to bump it up against our quality measures. It's unlocking other opportunities that I really don't know that we would have gotten the organizational buy-in or support to pursue if we didn't really have this rich and robust data set. So I think, as Emily mentioned, really, having it at the forefront of our community engagement strategy and being able to understand and showcase, where we see our patient populations struggling or, experiencing these health-related social needs, what geographies they're in, what resources are already embedded in those communities. We know through our Unitas platform who we're sending patients to. Like, that in and of itself is really powerful. You can really say, like, these are our top partners that we're referring to. What do we need to do differently to support that partner? Are they a trusted partner? Do we need to grow in our collaboration with them? What would that look like? And then I think I'd be remiss if I also didn't mention the importance of this data for our advocacy. As I mentioned, like, we are a safety net hospital. We provide some of the most care to our uninsured and our Medicaid population. And we're now able to showcase how this data impacts, the populations that we're serving in different ways, and to educate our state and federal legislators around what we're seeing as we're thinking about different opportunities to partner. I think it has helped us with conversations with our state social service agencies. What's their role? What can, WIC and SNAP and, our Medicaid transportation providers do above and beyond what we talk about with community-based organizations? It really is that full ecosystem of everybody partnering together to think differently about how to solve some very significant challenges that this data has helped us provide. And then I would say on the clinical side, what also excites me is having different conversations with clinicians about the clinical guidance that they can give their patients. So when we talk about food insecurity and things like that, or what prescriptions they're writing for individuals, can they afford those prescriptions? Are there other medications that they can consider? Have they educated them about their diet? And can we, get a dietitian involved? So I think there's the community partnership piece, but then there's also understanding, how do you think differently about providing clinical care, clinical guidance, knowing that these are challenges that your patients face, and that those are things that our clinicians are able to really think through with us. And so bringing that together, the social care and the clinical care are things that really excite me about this work.
Okay. And I'll open it up to Tony or Emily. Would you like to have any closing last thoughts?
Well, I saw a lot of questions in the chat about, closing the loop, and I think that's an important piece. We focused a lot here on the scaling up of the infrastructure and the technology to be able to just identify these needs and make sure that we're sort of providing a baseline response that's standardized across the system. But, this next level piece of it is when patients are working with community health workers or social care teams or anybody that's using the closed loop functionality of the referral network piece of Unitas, that goes beyond just identifying resources and giving patients a resource list. That's the next piece of it, is sending patients referrals or warm handoff type referrals through the system. And then there is a robust data insights tool that comes with Unitas that is able to capture, whether the referral was accepted, right? Like, was the referral appropriate? Is this patient eligible? Was it sent correctly? All the way to, did the patient respond? Did they receive the services? And I think, we're still kind of in a building phase with that, and understanding what that data is going to look like over time. But it is going to become, increasingly important for us to use that tool to understand sort of next steps. And that can inform everything from, where do we as a state put resources to, where are the gaps, which organizations or which service types are just not available right now. So I think there's a whole world of possibilities with that body of data as well.
I agree. And one question in the chat I wanted to touch on was the incorporation of patient feedback. So as we were designing our SDOH strategy, we did bring the questions and perspectives to some of our patient and family advisory councils for their input on, what questions would they like to be asked? What kind of topics are, important to them? What care team members would they feel comfortable sharing this information with? In what environment? Would they rather it be a self-screen, or would they like the support of a care team member, and whom, in what phase of a visit? And so I wanted to just mention that before we close today, and I'm really grateful for this conversation. But I also think, incorporating patient feedback into the process was really transformative in our development of our strategy to understand their perspective as well, because we want to use their information to the best of our ability and have that be informed by their lived experience as well.
Well, we have covered a lot here today. Such a meaningful discussion. I know we were trying to address quite a few of the questions coming through the Q&A, but any questions that weren't addressed, we will certainly follow up offline. That does conclude the time we have for questions. I'd like to thank our panelists for a wonderful presentation today. And thank you to our sponsor, Unite Us. To learn more about the content presented today, please check out the QR code on your screen here, as well as complete the post-webinar survey. In the next few days, all attendees will receive an email with a link to the archived webinar session as well. Thank you again to all of our panelists, and everyone have a great afternoon. Thank you.